All right, let's talk about one of neurology's great masqueraders. It's a condition that can look like an aneurysm, a stroke, or even vasculitis, but it is absolutely its own unique beast. We are talking about reversible cerebral vasoconstriction syndrome, or RCVS. So, picture this. You're in the ER and a patient comes in with that classic textbook thunderclap headache, the worst of their life. You do all the right things, you get the head CT, you do the lumbar puncture, and everything's negative for a subarachnoid hemorrhage. Okay, great. The patient's relieved, but you're kind of left scratching your head. What's next? Where do you go from here? And what if the patient mentions that this headache slammed into them right after a hot shower, or maybe during a workout, or even just from a bad coughing fit? I mean, these don't sound like your typical headache triggers, right? Well, these aren't just random details. They are huge clues, pointing toward this bizarre temporary vascular storm that's brewing inside their head. What we're unmasking today is exactly that, reversible cerebral vasoconstriction syndrome. It's a condition that every single emergency physician and neurologist really needs to have on their radar. And our guide for this whole explainer comes from two really fantastic reviews, one by Kim and colleagues in the Journal of Headache and Pain, and another by Avila and Pizzini. So what the heck is RCVS? Well, honestly, the name tells you pretty much the whole story. It's reversible, which is great news. It gets better. It involves cerebral vasoconstriction, a sudden clamping down of the brain's arteries. And it's a syndrome, a whole collection of signs and symptoms. The easiest way to think about it? Just picture a temporary cramp, or like we said, a passing thunderstorm in the brain's blood vessels. It hits hard, but eventually it fades away. Let's get to our first big takeaway, our first key point. You have got to suspect RCVS early, even when your initial imaging looks totally, completely normal. This is where that masquerader disguise really comes into play. And don't just take my word for it. The literature makes this crystal clear. Kim and colleagues point out that angiographic imaging can be completely normal within that first week. In fact, we know that up to 22% of initial MRAs show absolutely no abnormalities. Why? Well, the disease process is just getting fired up, and the imaging just hasn't caught up yet. This is why your clinical history is, without a doubt, king. This timeline really paints the picture of how this thing unfolds. So in week 1, the patient is having these explosive headaches, but the vasoconstriction itself might be too far out in the small vessels, or just too mild to see. Here's the kicker. The real danger zone is actually in weeks 2 and 3. This is when that vasoconstriction hits its absolute peak, and that's when the patient is at the highest risk for some scary complications, like ischemic strokes. But after that, the storm starts to pass, and the vessels slowly return to normal over the next few months. So if imaging can be normal, what clues are you hunting for in the history? Well, it's all about the triggers. You've got to ask about anything that involves a Valsalva maneuver. We're talking coughing, sneezing, straining. Ask about intense exercise or sexual activity. And this is a huge one. You have to review their medication list for anything vasoactive. SSRIs, triptans, even nasal decongestants, not to mention illicit drugs. And always, always keep RCVS in mind for a postpartum patient with a sudden, severe headache. Okay, on to our second key point, diagnosing with confidence. You know, we all learned about that classic string of beads look on an angiogram, but as the review by Kim and colleagues points out, the diagnosis is so much more nuanced than just one single imaging sign. And to help us cut through all that uncertainty, we have an incredibly helpful tool, the RCVS-2 score. Let's just walk through it real quick. A thunderclap headache? Boom, that gets you a massive 5 points. Having one of those triggers we just talked about, that's another 3 points. The presence of a small subarachnoid hemorrhage, usually over the convexity of the brain, adds a point. And so does being female. The only thing that counts against it is finding vasoconstriction in the big intracranial carotid artery, which is actually less common in RCVS. But here's the magic number, the crucial cutoff, a score of 5 or higher. If you get that score, the diagnosis of RCVS has a 99% specificity. I mean, wow, that is an incredibly powerful way to tell this condition apart from its mimics, right there at the bedside. And the most important mimic you have to rule out is primary angiitis of the CNS, or PACNS. Getting this distinction right is absolutely critical. Just think of it like this. RCVS is a sudden, violent storm. It hits with a thunderclap, the spinal fluid is usually clean, and the course is monophasic. It comes and then it goes. PACNS, on the other hand, is a slow, chronic smolder. The headache is gradual, it's progressive, the spinal fluid is usually inflammatory, and the course is just relentlessly chronic. You have to get this right because the treatments are completely different. Which brings us to our third and final key point, managing RCVS wisely. And this is really all about supportive care and, maybe most importantly, avoiding harm.
So here's the clinical playbook. First, the do's. You're going to stop any and all potential triggers right away. That means stopping those offending medications. You want to maintain a normal blood pressure, and for those awful headaches, the literature supports considering a calcium channel blocker, like nimodipine. Now for the don'ts, and this part is vital, because you've smartly differentiated this from PACNs. You do not give glucocorticoids. Steroids can actually make things worse in RCVS. And of course, you're going to avoid other things that clamp down vessels, like triptans.
Ultimately, the whole philosophy of management is just to be a good guide. You're not curing the disease, you're just helping the patient navigate the storm safely. The condition is self-limiting, so your job is to control the symptoms, watch out for complications, and just let the body's vascular system reset itself over the next few weeks. Okay, let's put this all together into a final clinical toolkit, something you can take away from this explainer and use in your practice. Here it is, nice and simple. Number 1, suspect early. The big takeaway is that imaging can lie to you at first, so your action is to maintain a high suspicion based on that patient's story and plan to repeat the imaging. Number 2, diagnose smart. It's more than just a string of beads. Your action, use the RCVS2 score and actively differentiate it from PACNs so you don't give the wrong and potentially harmful treatment. And number 3, manage wisely. The mantra is first, do no harm. You're going to remove triggers, manage blood pressure, and, say it with me, absolutely avoid steroids. Look, if there is one single thing you remember from this entire explainer, let it be this. The next time you work up a thunderclap headache and you rule out a bleed, don't just stop there and call it a migraine. Your very next thought should be, could this be RCVS? Because just asking that question and knowing what clues to look for next, that's the whole ballgame. It's how you go from being stumped by a mystery to confidently unmasking this great masquerader. Thanks for tuning in.